public systems come at par with the private ones, people will equally come to one or the other. You know a bit for that. Have you ever been hospitalized? Never, no? Have you been to any else? Yeah, we have seen some in Kenya, right? It's top of the range. I mean, it's the same quality of food you would ever need. I got a pay prices and everything. It's fantastic. Right? So before you think that, of course it's a good idea. It brings a lot of value. And what do we do in the meantime?
My activist, my Spaniard. Amanda, Amanda. Welcome everyone. My name is Nisek Dlamini. I'm the Deputy General Secretary of the Treatment Action Campaign. Thank you very much for coming here and dedicating your early evening with us. I'm here just to introduce our speaker. But before I do that, I'd like to really thank you, all of you, for coming here. And MSF Section 27, Shalco, and everyone for coming here, because I know that you have many things to do. As many of you will know that India supplies more than 80% of antiretroviral treatment to African countries, and affordable ARVs in India has been extremely important in bringing down the cost of the first-line regimen. Competitions between generic producing companies have, especially in India, have drove down the cost of antiretroviral medicines. For instance, medication that costed in 1990s about 5,000 rand per patient per month now could cost less than 100 rand per patient per month. And affordable medicines have allowed millions of people living with HIV like me to access antiretroviral treatment. And before 2005, India could produce cheap generic antiretroviral treatment from the 1990s and did not uphold intellectual property on pharmaceuticals. But then in 2005, India had to comply with the trade-related aspects of intellectual property rights, which is known as TRIPS, and therefore had to amend their national law, which is called the Patent Act, but to comply with the TRIPS. But then at the time, Indian activists fought for and won the provision of safeguards in their law to protect the health. But these safeguards are now being threatened by the ongoing challenges by a pharmaceutical company known as Novartis, and the agreement being negotiated with the EU. And this is pressuring India to remove their safeguards on the patent laws. Lina, sorry for the pronunciation, I'm Zulu, so we say things as you want. Lina is here to speak to us about the Indian experiences of pushing forward the pro-public health safeguards in its amendment of the Patent Act. And she's an activist, a lawyer, works with MSF, also works with the New Delhi Positive People's Network, and has been in Welcome to South Africa.
So before I start my presentation on how we have to continue the battle and how we started, I'd just like to say that I'm indeed honored. When I had my first job, I was volunteering in a feminist organization. A very senior colleague of mine told me, she took out a brochure from TAG and she told me this is going to be the movement that is going to change the nature of right to health. And indeed, when I started to work, I never thought I would come to South Africa. So it's indeed an honor to be here. And a lot of us in Asia actually have known about TAG, have been friends with TAG, Section 27, and all of the colleagues. So we're just really very honored to be here. I'll just quickly explain that this presentation has been put together in a number of forums by a number of people who have worked on access to treatment. So the Delhi Network of Positive People, very hot and very sexy, real organization who will burn, who will fight, and do a lot of the court cases. I think they just fired up everyone's imagination on access to treatment. There's Lawyers Collective, the civil rights lawyers. I think South Africa has seen a bit of a partnership between the networks and civil rights lawyers, and I think there's something very common, and I think we must keep it going. The civil rights movement must continue to work with the networks to fight for access to treatment. And there's of course Gopa Kumar, a very silent but very quiet but an amazingly respected activist in India. He tries to be very polished because he works with Third World Network, but he's fantastic and he has pushed a lot of us, including me, into doing this work. And I must say that the People's Health Movement and the health movement itself has started to understand why we ask for the most expensive treatment to save our lives. They started with saying that HIV drugs are too expensive, what you're asking for will lead to the collapse of other treatment programs, but now we know that HIV/AIDS programs can transform the whole nature of public health programming. So we are now starting to work much more together in India and Asia as well. We have always been concerned about patents. In India, at one point you have a battle where you have to get a particular drug into a program, like to move Stabdini out and you want tenofovir. So you have to take daily policy decisions on protocol. On the other hand, where will these drugs come from? So you always have to worry about whether drugs will be available in the right quantity, will they be registered, will they be in the right quality, and everything that goes into it. And what is the biggest barrier? You're constantly looked at the patent status. So it's always been there at the back of our head. And I think the MSF's access campaigns, technical work on it with Indian activists has played a crucial role in us moving forward so quickly on some of the work that we've done in India. And I think MSF Access Campaign in India was set up not only to look at its own cohort in India, but to look at across the developing world. And I think it sort of plays that role quite actively. We do know that 90% of pediatric ARVs that exported out of India go to developing countries, large number of ARVs, but that's just the tip of the iceberg. We know many other drugs that go out of the country for patients, including my drug. I'm an asthma patient, Montecular sodium, an expensive Merck drug, is starting to be exported for asthma patients across the world. So India has been sort of the pharmacy of the developing world, and we've always worried about the patent status of a particular drug. So before you can actually produce it and export it or use it in a national program in India or get it from the private sector, you have to worry about the patent. We had a fantastic time of a safe haven kind of, as I say. From 1970 to 2005, we didn't have patents. And we built that law because we already, before 1970, we had a British patent law, which is pretty much like the TRIPS law today. And we had monopolies. The GSAs and AWACS actually ruled the Indian market. They were very expensive. We couldn't, the Indian government couldn't provide access, and therefore went back to the drawing board and said we have to do something about it. We also didn't have the technology, and no one would give us the technology. So we had patents, we had no technology, and we had the highest prices in the world, well documented in a parliamentary research done by parliamentarians themselves in the late 60s. Everyone knows, I hope, what a patent is. Just to refresh our memories, I think it's part of all our workshops. When you have a patent, you have one producer, you have a complete monopoly. You really can't go to a competitor and buy it from another company. So when you don't have a patent, you have multiple producers, preferably more than 4. You have competition, and then you can sort of find a price that you can afford. Either the government negotiates bulk prices, or patients in the private sector access those prices. So that's what a patent does. So if you have patents, you don't have multiple producers. And this all came about because of this brilliant strategy of Indira Gandhi. She was a politician, and she basically said that you can't profiteer from medicines, and patents are a barrier. And she did this wonderful speech at the World Health Assembly, and she had already drafted the patent law, which did away with patents, sort of, so to speak, in pharmaceuticals and food. These are 2 areas we refused to have a monopoly on. One was food, and in which the Green Revolution on food in India was built, and the other was medicines. We couldn't have a patent on medicines, and that's how we built the entire generic industry to provide medicines to our patients. And she basically was the architect of that law. So from 1970 onwards, no patents. We set up public sector units and trained medicinal chemists to produce a technology, to make the raw materials, do the formulation, and the public sector units played an exemplary role in setting up the industry. So public sector units gave technology, gave people, know-how to the private sector to sort of set up the Indian generic industry. So from 1970 to 2005, you had the industry moving quite rapidly, and particularly today we can actually reverse engineer any drug that we want to. Any drug means any drug. We are struggling on biosimilars, but I'm sure we'll manage that as well at some point. And all of you know the history of AIDS treatment. We were all struggling with AIDS treatment in 2001. Indian producers offered in 2001 a price which was far more affordable. So from over $10,000, we saw $350. Today the same stavrine-based treatment is $60. That also speaks for improved first line. For improved first line for tenofovir, when I started to do the work, it was over $5,000 per patient. It came down to $800 per patient when the first generic came in. Today we have 4 generics, and it's less. It's about $150 for a fixed dose combination of tenofovir. So that's the kind of crash we've seen on tenofovir itself. So actually the principle proved itself right again with tenofovir, which is now we're struggling to get into the national program. So that's a battle the Delhi network and all of us are fighting in court. We got the fixed dose combinations going as well. No patents means you can fuse the drugs together and come up with fixed dose combinations. And that was the reason why I think the Indian Patent Act was so useful for public health, because it was not just about prices, it's also about making pediatric versions of a drug, making the fixed dose combination. So you could do all of that because there are no patent barriers. It was easy to make these different formulations. And that really helped in getting AIDS treatment off the ground. Same happened on cancer. Imatinib is a blockbuster drug, or I'd say life-saving drug. I don't want to use pharma language at all, but it's a life-saving drug for chronic myeloid leukemia. Previously, many people died of chronic myeloid leukemia. It's pretty much like an ARV, it keeps you alive for many, many years. And it was a drug that was very expensive. Even now, for a month's treatment, in developed countries, you pay $2,500. In Brazil, you pay upwards of that. In Korea, you pay upwards of that. And the Indian companies have made it less than $300 a month. And Cancer Patient Aid Association basically gives it free to its own cohort of patients. So even on cancer treatment, we saw the Indian companies build generic capacity. And I'm going to come back to this drug because the biggest battle on access has been centered around this drug and the law to get the patent on this drug. So I'm just going to come back. That's why I put imatinib on the map, because cancer groups, Cancer Patient Aid Association, a fantastic organization who doesn't take pharma money, actually forged alliance with HIV/AIDS groups to fight the access battle. And that's how we were able to fight some of our patent battles. Everyone's seen this picture probably in South Africa. India becomes a pharmacy for HIV drugs, and we move on to start thinking about what we want to do next. Till 2005, many of us, we did not know the value of the 1970 Act. And it was a landmark meeting that happened in Mumbai, that suddenly everyone, all the activists, Latin Americans, the South Africans, everybody was in the same room and said, we got to fight this battle. And suddenly we were on a plane to New Delhi to fight a very big battle on the 2005 amendment to the patent law. So very simply, we were very, we should have been more astute. We signed a trade agreement in 95, which basically said in 2005 we got to bring the patents back, which we had removed on medicines and pharmaceuticals. Not a very smart move, but nevertheless we did not know what it meant, or we knew, but our governments gave in to the pressure. But in 2005, we woke up to the reality. And this is a poster. When we realized, we started to discuss among Indian groups, and we realized the value of the Indian law, we started to fight back. We didn't want the law to change. We didn't want the patents on medicines. We didn't want it. So countrywide protests, the leaflet in regional languages, we had to sit and, as lawyers, simplify it. So, movements could start working on this. But what was amazing was the kind of international support Indian activists got from all over the world. So you have South Africa, you have ACT of Paris, you have MSF, you have pretty much everybody already moving very fast. Health Gap in the United States. And we were actually very new to the whole thing of fighting in a campaign mode. But one thing we did get, while we were inside in Parliament and the international movement was moving outside, we got 5 big things in the new law. Of course, we followed the international TRIPS agreement, but we got one thing that was really very important: the right to examine a patent application, which does not exist in South Africa. So a patent application that is made has to be examined by the Indian authorities. They cannot just grant it because the United States or the Europeans or someone else has granted it. They have to do their own examination. And around it, what we did, not only do you have to examine it, but we said TAC or the Brazilians, Delhi Network of Positive People, I, Michelle, anybody could file a patent opposition. That means you could oppose the grant of the patent. And that were the 2 things that actually helped us a lot. We said it has to be examined locally, and we have the right as patient groups to oppose a patent that is going to be granted. If we think it is a rubbish patent application, it should be actually not, it should be rejected, then we should have that right. Now we had to really fight for this because Americans were telling the Indians, remove the right to file patent oppositions. And what they did not realize was, not only did we ask for local examination, but we asked for a very tough system of examination, which was Section 3D. So you just don't get a patent if you take 2 drugs and put them in one pill, or you produce a pediatric version, a child version of an old drug. I can give you a number of examples like that. When you use aspirin as a blood thinner, a new use of an old medicine, you can't get a patent in India. So new use patents were curved, and if tomorrow you have a tenofovir and someone wants to put it together with rilpivirine and lamivudine, you will not get a patent in India. Just putting old medicines into one pill does not constitute a patent. So these are things we really fought for. And I'm saying this because I know that in South African law it does not exist. And of course compulsory licensing, and of course the Bollard provision. I'm going to come back to the Bollard provision because it allows for the local registration of the drug in India, even if it is patented. And it has been immensely useful in the battle on access to cancer drugs. So let me give you an example. So nevirapine was something that was invented in 1990. And everyone knows nevirapine because it's been used so extensively in the first line fixed-dose combinations. And the patent was supposed to expire in 2010. Now India didn't need to grant it because it was before we signed the TRIPS agreement. But what did Boehringer do? It basically filed for the syrup formulation, for the child formulation. And we had to oppose that. And then now what they have done, it's a slow release formulation. You take once a day nevirapine. They tried to file for a patent on a drug that was invented in the 1990s. In 2010, many years, 20 years later, on just a slow release formulation. Now the Indian law doesn't allow for all of this. So this is the way companies actually do evergreening. We call it evergreening.
And of course, what we did was, we started to file patent oppositions. Lamivudine, zidovudine, fixed dose combination, nevirapine syrup, tenofovir. We rolled out the opposition one after the other against the pharma companies and their patent applications. Very difficult. We went to each patent office, they tried to hide the information, but we used to say, we will not go till you give us the document. And one thing that I had in my favor was I was heavily pregnant. So, having a pregnant lady in your office saying she's refusing to leave was very good. So every time I would get on a plane, get off, and I would go there and they say, sorry madam, we can't find the papers. I said, sorry, I cannot leave your offices. I have a right to information and you have to give it to me. So I went down the patent offices trying to collect the documentation. And we were lucky enough to get the sympathy of the patent offices and get some of those applications out. Very difficult to get information out of your patent offices. They always try to hide information. So very difficult battle, but we managed it somehow. And we played, what we did was, the lawyers and the activists came together. So lawyers would file the patent opposition. They would go and tell the patent office, please don't grant this patent, it's a fixed dose combination. Lamivudine and zidovudine. And what would the activists do? Be outside and protest. So this is a typical case where this is lamivudine, zidovudine, patent opposition. Basically, lamivudine, zidovudine is combined together with the help of sand. That's what it was. So we threw sand on the GSK office to make a point that this is how bad your patent is. And the Thais joined in, who also had a patent application on it, and it got withdrawn. GSK got very embarrassed and withdrew the application. Tenofovir, we wanted people to move out of stavudine. Children going to school, they were getting stigmatized, we knew the side effects of stavudine. We wanted better first line. So the only way was to get access to tenofovir. So what did we do? We said, Gilead cannot get this patent in India. And come what may, we will block it. So we filed patent opposition after patent opposition. Luckily for us, the drug was invented in 1986. So that was a good part of it. So what did they try to do? They were very smart. On tenofovir, they said, it's a pro-drug. I don't know whether anybody who has a pharmaceutical background over here, but basically when you want to make it easier for your body to absorb it, you cover the drug in something and you take it. So it goes easily into your system. It's called a pro-drug. And a salt. So what you do is, it's a base, you pour acid on it. I'm making it too simple. Then you get different salts and you see which is the best, which is more stable and all of that, and you use that salt. Very common, any chemist can do it for you. It's standard pharmaceutical procedure. But of course, the companies say it's inventive. It's a big invention. So that's what we did. So we just showed the textbook, pharmaceutical textbook, to the patent office that Gilead was just basically rubbishing us and playing us for a fool. And outside was Loon from Delhi Network taking his entire lot out and fighting it out publicly, holding huge rallies, telling the Indian government you can't grant this patent, making it extremely embarrassing for Gilead to get this patent. But Gilead, of course, wanted to come and meet us. And they said, madam, why don't you withdraw your patent opposition? We will give you a beautiful voluntary license. The Indians will have no problem. But what did we do? I should actually come back to it, about tenofovir. So we filed more oppositions. We just did not give in to that. Because why? The way they did the voluntary licenses, they kept some of our colleagues out of it, like the Brazilian colleagues out of it. So the Indians could get it, but the Brazilians couldn't get it. So there was a problem. It was a divide and rule game that they wanted to play with us. So they came to Delhi Network of Positive People, they came to us. We were very nice to them. We had tea and coffee together. But what did we do? We went back to the Brazilians and said, Gilead is coming after you. Let's file an opposition. So the Brazilians filed an opposition in India against Gilead's patents. So we just went after them. We just wouldn't back off because our Latin American friends couldn't get access to the drug. So it was just not about Indian battle. It was, we knew very well that if the Indians produced, you still had to make sure the drug reached other countries. So the battle for the Indians is more difficult because the pharma companies always come and wish us happy birthday, Merry Christmas, and try to give us gifts, jobs, donations. Very difficult to keep withstanding that kind of pressure. But we try. You just gave back dirty Johnson & Johnson money to them. And we also fought on the cancer issue. We did not give up on the cancer drug. So this drug was something that Novartis wanted a patent on. Why? Because it was a blockbuster drug for them. They had already turned over 7.5 billion in a matter of 5 years. The Indians producing the drug meant it would go to other developing countries. They were competitors, so they wanted to block us. So what did the HIV/AIDS groups do? They got together with the cancer groups and said we will file an opposition to imatinib. And this was the first opposition we learned. We filed the AIDS ones later, we filed this one first. And it was again a salt formulation of an old cancer drug. And we won that case. That was the first sweet victory we had on the patent oppositions. And we basically fought our way with Novartis to gain access to this drug, which they had blocked quite effectively. This was a drug that had been funded by US taxpayers' money. So it was we were all the more angry that the research had come from taxpayers' money, but they were blocking access for patients in developing countries. So they got tax credits, they got grants, they got waiver of FDA prescription, name it, they got a bunch of waivers from the US and the EU government. So what did they do? They said Indian law is very bad. It's not badly drafted. Indians are complete fools. They don't know how to draft the law. They're not TRIPS compliant. They don't know the constitution. They filed a big court case against the cancer groups and the Indian government in the Madras High Court. I know India is a little confusing in terms of geography, but one of the high courts, they basically went after the Indian law. Not the patent for the drug, but the Indian law. So we were worried that if the patent law changed, then the patents on HIV drugs and other drugs would start flowing. So we decided to join the campaign, and the Novartis Drop the Case campaign was born. So AIDS groups are very prominent in that. They took the lead in it. And of course, MSF joined in with Novartis Drop the Campaign. And it was a huge, huge campaign with the scientist who invented imatinib speaking out. He's a brilliant oncologist, Brian Drucker, who said, I did not do this work, or public labs didn't do this work, so that patients couldn't get access to it. So he spoke about evergreening, and he wrote a very, very interesting editorial. This editorial by Dead Man Walking, interestingly, is by a patient who took imatinib. His name is Richard Rockefeller. He's also on the board of US. He wrote a brilliant article for MSF on both the cancer drug and the AIDS drug. So it was very high, it was big stakes for us. And of course, the AIDS groups did not back up. So we got beaten up, we got pushed back, but we would keep going. Every time the court hearing would come, we would go out on the streets and fight back. And it was so prominent in the papers that Novartis actually complained to the court that patient groups were trying to influence the outcome of the case. And we were quite, we said yes, we are trying to influence. Come get us. Who will you arrest? That was really funny because, you can complain and all the more the judge was saying, why are they complaining? What is the problem? And of course the whole access issue started to get discussed in the court. So it was really funny, it backfired on them. The problem for us is that we got a brilliant law, but still new medicines will get patented. That means drugs that were invented after 95 will still get patented. Does not mean we will not produce them. I'm sure we'll find a way of producing them, but the problem really is they are patented. Now, a lot of my friends and colleagues who are in HIV positive networks are actually dying of hepatitis C. It's a co-infection, moves pretty much like HIV, but actually it's much more effective. Each injection basically costs about $300 per week. And you have to be on it for 48 weeks if you're HIV positive. If you're not HIV positive, ex-drug user, the history of drug use, you want to take Hep C treatment, you have to take it for 6 months, you have to pay $300 every week. That's unheard of. No one in Asia can actually afford it. But that's what Merck and Schering Plough are doing to positive people in Asia. Then the cancer drug sorafenib, it's used in some forms of renal and liver cancer. They basically priced it at, I'm just counting how many $1,000. It's about $5,000 a month. And we can make it at $110. We can probably make it at $50 a month, even less. The generic companies make a lot of money out of it. So the cancer groups are struggling with access as well. And of course, we have problems with What will happen to new TB drugs, TMC 207? Some people need it quite urgently because they have drug-resistant forms of TB. What about third line? Even if it's a small cohort of patients, because if we do first line and second line well, we still will have a few patients, particularly in India, because the private sector made such a mess of AIDS treatment and TB treatment. We need access to the new TB and HIV drugs. We are not arguing for them to come through the private sector anymore. We are saying the government should treat according to a protocol set by the WHO, but still we need access to those drugs. What do? They are patented. MSF in India pays more than $4,000 for third line salvage therapy for HIV. 6 patients, we probably have 20. Should we keep paying 4,000 euros per patient? A big question mark for MSF in India itself. It's the only organization that does third line in India, salvage therapy. So we'll have to think what Thailand did. Thailand issued compulsory licenses and brought down the prices of ARVs, heart disease, and other drugs. Majorly, if you look at clopidogrel, which is a heart disease drug, from 70 baht came down to 7 baht, which is really a big price reduction for the heart disease drug. So we'll have to now fight the battle on compulsory licensing. And I don't think so we want to be alone. We would like everybody to come together because the drugs are made in India. So the CL battle is going to be huge, because getting up CL from the Indian government will not only be about the law, it will be about the politics of international trade and other issues that will come into it. But despite the fact, we just keep going on. The battles just keep rolling into India because we keep producing the drugs, we've got the competition, and the onus sort of lies on the Indian groups to keep fighting some of them. So we've got trade deals on the horizon, and of course the EU wants to sign one with us, and the US wants to sign with us, and they're so nice to us. They're giving us, again, intellectual property measures that we must adopt. And I think it's very important to talk about this, because it's not about just fighting the Indian FDA. It's all over Asia. It'll come to Africa as well. And they will never show you the text. That's the problem. They keep reassuring you there's nothing that will affect your medicines. Till you see the text, I think you should not make up your mind that this trade deal will do us no harm. So this is a very important part of a battle of gaining access. Our problem really is in India. If India signs a free trade agreement, the dream of putting 15 million people on treatment by 2015 will be basically lost. We cannot possibly think that India will not grant a large amount of intellectual property and we can still get the drugs out of India. Not possible. So that's a big problem for us. There's no transparency. They won't give us the text. So we have to fight it out and try and get a leak from somewhere. Amazing, with the constitutional right to information and so many other constitutional rights, we're still not able to argue access under our domestic legislation to trade deal X. What do they want? More than 20 years of patents. What do they want the Indian FDA to do? Not to register a generic version, even if it's not patented. So if I do a trial and I produce data and I give it to the Indian FDA, the generic will either have to leave the market or cannot enter the market. How does that happen? I'll tell you a story. It's a brilliant story. I think it's a brilliant, whoever lawyer thought of data exclusivity was probably fantastic. So colchicine is a 3,000-year-old medicine, which is known to work against gout. It was already available in tablet formulation. Can you imagine having intellectual property on a 3,000-year-old medicine? So a company basically did a trial on 50 patients showing it worked for gout and registered it with the US FDA. It was of course an off-label use that had been continuing of a traditional medicine. But because they submitted that data first, they were able to push all the other companies out of the market. And that drug, colchicine, moved from a few cents to $4 in the US. That's how data exclusivity operates. Do a small pediatric trial, do another trial. It's an old medicine, does not matter. Do a trial on fixed dose combination. You can get data exclusivity. It does not have to be patented. So it's a new set of rules that we had to follow. And that's why we are opposing it so heavily, and MSF was opposing it so heavily in the FDA. I'm not even going to talk about this. In Jordan, the prices went up by 800% once data exclusivity rolled in. Terribly, I mean, it's happened to Guatemala, it's happening to Colombia. And of course, So the EU has been seizing drugs on its own borders. Now it's telling us, Indians in the FTA, you should also have border measures. So our customs, Indian customs, can actually seize medicines at Indian ports and airports. So the Bombay Port Authority, the Calcutta Port Authority, the Chennai Port Authority, the ports will basically, Indian ports will stop medicines from going out of India. So these are the kind of measures they have come up with. So lesser known, but they don't want the medicines to reach African shores or Latin American shores. So this is the kind of provisions they've come up in the free trade agreement. I think there's something new that not many people have watched. I think the South Africans probably know it better because some of the laws got challenged. But intellectual property also becomes investment. And if you devalue an investment, you can sue the government. How can you do that? Philip Morris has done it. Uruguay, Australia, wherever you have warning labels which are very big on the cigarette carton. Has anyone seen them? Big warnings. You're taking away the right to broadcast the logo and the brands. So you're taking away the IP rights, the trademark rights as they call them. And the moment you do that, they sue you under a investment provision of the free trade agreement. Now a pharma company can do the same thing. Pretty much if a country issues a compulsory license or does price control on expensive medicine, they can go and sue us. Sue the Indian government or any other government. So a big warning. The tobacco case is a big wake-up call to those who work on access to medicines to take a look at the investment provisions. What did we do? We had to get access to the text. We had to write letters, protests, go back to the Department of Commerce. We never really liked the Commerce Ministry much, but we had to make friends with them. Responses to the EC, who kept telling the press, there's no problem in the free trade agreement. Media actions and highlighting the Indian government actions. What is the Indian government's position? Very important in the whole issue. And working with a broader coalition. The Indian groups have started to work with dairy farmers. They started to work with groups who work on right to food and the free trade agreement. But I think the most important thing was, in India, you couldn't protest anywhere. The Commonwealth Games were going there. So if more than 4 people got together anywhere, you would be arrested. So the Commonwealth Games were on, and we decided to do a protest in front of the Ministry of Commerce. So 2 truckloads of police officers came with batons and guns and beat us and chased us out of that. So unfortunately, as in most protests, we wear HIV positive t-shirts. So they could chase us. They were hauling us and beating us mercilessly. But that actually fired I think all developing countries, all networks got really angry about what had happened and got together to fight this. And that's when the protests spread in Asia, for example. So there was Indonesia, Malaysia, Korea, meetings for next moves. People came from Nepal, and we came up with a big rally in New Delhi. And people traveled from all over Asia to come for this rally. And you can see the thousands started to get together in New Delhi to fight the free trade agreement. Huge press conference with the cancer groups, Lawyers Collective, Delhi Network of Positive People, very well carried by the press, good interviews and explaining what the consequences of the free trade agreement were. And I think just a few articles that went out from AFP, CNN, IBN, Al Jazeera, and we really fought to get all of this going. So it was Europe, hands up medicine. We really didn't want them to come near our medicines. So this was the big campaign that we fought last year. Of course, we continue to fight the cancer drug and the Novartis campaign because they continue to try and challenge our laws. How do we do it? I think a big question for a lot of groups who work on this. We did a lot of actions around legal action. So we filed a court case, or we intervened in court cases like the Glivec matter imatinib case against Novartis, and we filed our own interventions. We mobilized community. We were constantly working with community. Loon and others who were members of the community were talking to their own people and building a lot of capacity to understand Loon basically believes patent issues are not complex. He can explain data exclusivity better to a lot of people than I can. We did media advocacy, we did direct action. We were not scared of being hit by the cops or being beaten by the cops. I think now I think even if they break my arm, I'm not so worried about it, or like write a first information report, I'm not so worried about it. I used to be, but we are less worried about things like that. International action, a large amount of it, the responsibility was borne by MSF to talk to Oxfam and talk to the European Union, get information out. Huge plus also the fact that Latin American groups supported us and the Asian groups supported us, and many they were protesting.